So I was thinking about how to run today's rounds, as far as what case we should do together. If you look on, let me see if I can share my screen one sec. For whatever reason, I can't share my screen right now. Okay, I think I got it. Can you guys see my screen? I can't see the chat, so somebody has to say yes or no.
Yes.
Yeah.
Okay, cool. So we were gonna go through one of these cases. I was gonna do the chest pain, one of the chest pain ones, just because you guys have done chest pain, and I forget if we've done the abdominal, all of the abdominal pain ones. But I figured since it's the last time, we're gonna be together and talking together, whatever. I was gonna let you guys choose whichever case you wanted. So there, I think somebody asked if there's a PEDS case. I think there's a cough. Yeah, cough in a 2-year-old boy, and then there's a scrotal pain in a 10-year-old boy. I don't see anything else. Yeah, and I also don't know if I don't know how relevant it will be to what we've taught, but if you guys just want to do something, then or that we can all learn from, I'm okay with you guys choosing whatever you want. So what I'm gonna do, um, all right. Why am I still presenting my screen? Okay, what I'm going to do is I'll let you guys talk about it amongst yourselves, and I will be back in about like 5-ish minutes, and then if one of you guys can, or just let me know when I come back, and we can start the case then. Cool.
I'm good.
Okay.
So did we decide the 2-year-old with a cough? Maybe just like say yes instead of flooding the chat.
Yeah, I.
Yeah. Yeah, that's cool.
Yeah.
Yeah, good.
Yeah.
Yep.
Yay.
right, guys, is everybody ready? It looks like, for the most part, people wanted the PEDS case, which I was kind of hoping you didn't because it's been such a long time since I've done PEDS. But whatever. I'll struggle through this with you guys. Is that okay with everybody? The 2-year-olds with a cough, is that fine?
Yes.
Yeah.
Yeah.
All right. And then everybody can hear me okay too, right?
Yeah.
Yeah.
Okay, cool.
Yeah.
Any questions before we get started?
Dr. Abbas, are we going to talk a little bit about how in PEDS cases,
I'm sorry,
anatomy?
how about?
Oh, I'm sorry. If we're going to talk about like how PED cases are a little bit different than regular adults because of their anatomy.
Yeah, I mean, we can. It will depend on what the case eventually ends up being. If it's a cough, I guess it'll depend on what it is. Was there something specific that you're asking about?
No, not really.
Okay. So yeah, if there's anything different from the adult, we'll definitely talk about it. But just also remember that I'm not a pediatrician, guys, and it's been a while since I've done peds, so I'll do my best. Yeah, and if there's any questions, I might ask you guys to look something up for me too. Okay?
Okay, thank you.
Cool. Okay, so let's get started. So we have a 2-year-old boy who's coming into the ER because by his parents because of a 1-day history of cough and difficulty breathing. The boy appeared normal until the previous night when he began coughing shortly after dinner. The cough stopped after about an hour. He felt better and went to bed. In the morning, the cough returned and began to have difficulty breathing, which the parent thinks is worsening. No one else at home is ill. Okay, so the way that I would interpret that, and there's not a ton of information there, just that the cough is pretty acute onset. So started what seems like yesterday night as he was eating dinner, or after dinner. So it started shortly after dinner, stopped for about an hour, and then he was able to sleep, and then and then woke up the next day with worsening cough. So that's a pretty short course of his cough. Dr. Sai is saying maybe a foreign substance, so basically an aspiration. Dr. Villagomez is saying as well. Dr. Nassim is saying maybe asthma. Potentially, we don't know what the patient's history yet, so we can go on. Any other thoughts about the HPI? Allergies, asthma, yeah. Okay, yeah. The only thing about allergies, though, is if this was an acute allergic reaction, it wouldn't necessarily get better and then get worse again. Usually that process is ongoing, and if it's going to be causing shortness of breath or difficulty breathing, it's because you're having narrowing of the airway, which would probably, for the kid, he probably wouldn't be able to go to sleep, if that makes sense. But let's get some more history on him. All right. So he has no fever or malaise. He was well until the cough began. No rashes, no sore throat, runny nose, ear pain, difficulty swallowing, eye discharge, or redness. He's been coughing, and he is short of breath. No chest pain. Okay. I was gonna say, I don't know how reliable this ROS is on a 2-year-old. Okay. No abdominal pain, vomiting, diarrhea. He did not want to eat breakfast because he was coughing so much, and everything else was negative. All right, what do you guys make of this? And anybody can speak up. Okay, Dr. Sean, why don't you give us your thoughts? Because that's kind of what I was thinking too.
I was thinking that it's most likely not a infection because it says in the review system that they don't have like a sore throat or no fever.
Yeah, exactly. So the acute onset of the symptoms plus like no fever or no fever, sore throat, no runny nose, no ear pain, nothing like that. It makes me also think it's probably not an infection. So yeah, I agree with that. Anything else in here that's important? Maybe bronchospasm, but no chest pain. Yeah, if you have a severe bronchospasm, you can potentially have some chest pain with that. Worse with food, I think. If it was like maybe a severe GERD that's causing reflux and irritation of the airway, causing the cough, and then maybe that's why he's not wanting to eat. That's potentially, yeah. Okay. No, it didn't say what he ate for dinner. Okay. You guys want to move on to the next part? Let's move on to the next part. All right, past medical history. So full-term normal delivery. He's been healthy except for 2 episodes of wheezing, which required short course of bronchodilators but no daily treatment. So I think somebody mentioned asthma. So potentially he has reactive airway disease or asthma. If he has no difficulty swallowing, does that guarantee his airway is completely open? So if he doesn't have difficulty swallowing, that means that his esophagus isn't impacted. And it depends on where in the airway. So if you have a very high level obstruction, then yeah, they're probably not going to want to eat because they can't breathe. But if it's lower down, so like let's say he did aspirate on something, a carrot or whatever it is that he was eating, and it goes all the way down and hits one of the more segmental parts of the lung, he might be able to eat still. He just probably doesn't feel good because he's coughing and he's short of breath, but he would generally be able to still survive. So it depends on where that foreign body is lodged. Yeah, so there's no swelling in the esophagus, and I think we can assume there isn't. Yeah, so Dr. Shreya is asking, so the upper airway is probably fine, the lower airway might not be. Yeah, if he had an obstruction super high up, he's not breathing. That's like a choking event where the patient is starting to turn blue. You're trying to do the abdomen thrust to try to get that out. I mean, and hitting on the back actually is what we do for peds. So yeah, so probably not super high up. On the review systems, he said that he didn't have any chest pain, and so the reason I was saying like I don't know how accurate that is if you've ever interviewed a 2-year-old, I don't know how accurate a review of systems would be. He can talk, but you know if you ask a 2-year-old, hey, do you have chest pain? The answer is going to be variable. So, okay. Did they figure out why he's wheezing in the past? So it looks like it probably some reactive airway disease requiring some type of bronchodilator. So potentially asthma, but we don't know. Dr. Sai is saying the mom has asthma, which it looks like she does. So no surgical history, no meds, no allergies. The father is healthy. Mom has mild, well-controlled asthma. The kid lives with the mom, dad, and a pet dog. Vaccines are up to date. That's a good question. When did he get the dog? If he got the dog recently, then maybe it is an allergic reaction. Though it would be weird for this presentation to happen right at this moment as acutely as it did. So, yeah. Okay, let's move on to the next segment. So physical exam. So well-developed male child, awake and alert, who has obvious dry cough and mild respiratory distress, no cyanosis, able to speak with normal sounding voice. Okay, and then they give us the vitals. So who wants to interpret those vitals for me?
Can I interpret them?
That.
It's
If you,
it's
yeah, go for it.
Nassim. Okay, so I think his temperature like 37 degrees Celsius. It seems normal to me because I think that's like 98.6 in Fahrenheit.
Yeah.
And then his pulse. So I guess like in an adult that would be high, but I remember you saying that in kids it's normal for their heart rate to be higher than an adult's, I believe. So I think his pulse is normal for a toddler.
Yeah, I'd have to double check that. I think it's either high normal or just slightly elevated. But let me double check. Yeah, keep going.
And then his blood pressure, I think it's okay. Maybe I think it's fine. And then like his respirations, I think they're okay too. I'm not too sure about the respirations part.
So, okay, so the blood pressure looks okay. The normal pulse in a 2-year-old can go up to 130. So I guess technically this is going to be on the okay side. And then you said the respiratory rate. I think the respiratory rate might be a bit fast, but I'd have to double check that too. Okay, but yeah, the temp is normal. What about cyanosis? What does that tell us? The patient doesn't have cyanosis, but what does cyanosis mean?
Mean that he's blue, so he's not blue, so that means he's getting good oxygenation.
Yeah. So if you have a patient that has like a choking episode, you'll start to notice their face will turn red first, then purplish, and then you'll see typically around the mouth or distally as they start to become hypoxic, so they're not getting enough oxygen. They'll start to turn blue, and so that's what cyanosis means. Good. So yeah, so the respiratory rate for 2-year-olds is, it looks like between 25 and 35, or 25 and 30. So if anything, it's a little bit tachypnic, or the high level of normal for that patient. Okay, so all right, let's keep going. So the patient is pink, warm, dry, no cyanosis or rash. Cap refill is normal. Tympanic membranes are normal bilaterally. Nasal passage is clear. No discharge, no drooling, no erythema, no or exudator in the pharynx. Non-tender, supple neck, no adenopathy. Does anybody want to interpret the ear, nose, and throat exam? It's all basically normal, but what if we had a patient that was drooling? Does anybody know what that would be indicative of? Not necessarily a stroke. Croup, not so much. Dr. Shakil, do you want to talk about what you're about airway obstruction?
Yeah, so I actually have personal experience because last summer I did an EMT clinical, and one of the kids, they had trouble, they had a cough, and there was a little sort of like a wheezing type cough, I want to say, and drool, and I think they swallowed a little like Lego piece, so they weren't unable to swallow the drool essentially. So that could be a sign of an airway obstruction.
Yeah. So what we usually see, and what we typically would worry about, though here not as much, is shoot. epiglottitis. And so the reason why is the bacteria that typically causes it, we have a vaccine against now, so it doesn't cause that the death that it used to in kids. So, but what would end up happening is that part of the throat would swell up so much so that it causes an obstruction of the airway, and so it can swell pretty quickly. So what you would see is kids that are tripoding, so they'll be sitting forward, and you probably can't see, but they'll be sitting forward, their neck extended, and then they're drooling because they don't want to swallow that saliva down. And so when you see a kid like that, you know that they're in significant distress. And so that's one of the things that you want to take a look at is their general appearance, how they're sitting. Are they sitting comfortably? Are they sitting forward? Do they look like they're really struggling to breathe? But yeah, so that can indicate an airway obstruction. Good. All right. So, okay. And then I think everything else is okay. The fact that there's no erythema or exudate in the pharynx is important because it tells us that this is probably not strep throat or some other type of oropharyngeal inflammation. So POEM, I think Dr. Safe had mentioned it already. You want to talk about it?
I'm sorry, talk about what?
Talk about the pulmonary exam?
Oh, yeah, I can talk about that. So yeah, there is I guess when they were checking lung sounds, they found that the left lung appears to have wheezing sounds, but the rest of the lungs are clear, except for the part that the wheezing is kind of showing towards the right lung too. Wheezing, just by personal experience, wheezing, because I have asthma too. It's usually a case with asthma, and just by experience as well, I think that's probably just instantly. I'm leaning towards asthma.
Yeah, so asthma can definitely cause some wheezing. Typically with asthma though, it's not a segmental obstructive process. So you're not you don't just preferentially obstruct one part of your lungs. You can have areas that are a little bit more wheezy than others, but typically it's throughout your lungs that you hear the wheezing. So you know, it's possible that this is asthma given the history as well with the previous episodes of inhaler use. But what else can cause wheezing like this in one specific area of the lung? What else can you think of?
Maybe some sort of mucus buildup, just particularly on that side of the lung. I'm not quite sure if there's any particular disease or condition that can just be specific on one side of the lung, but yeah. Oh, like some people are saying fluids in the lungs as well.
Yeah, I mean, yeah. So what we were talking about earlier, you know, this happening after dinner, potentially him aspirating something. If it gets lodged in one of the larger airways, that can sound pretty wheezy, right? So if you have an upper airway or like a higher up obstruction, it would sound more stridorous, where it's like I can never do it, but it's like that sound, where they're really struggling to bring the air through a more narrow passage, but the wheezing is kind of lowered down, and that can indicate that there is something stuck in the lower segments of the lung. The other thing, typically with like a pneumonia, it usually wouldn't cause wheezing per se, but most of the time you'd hear some type of crackles or rails. But you know, it can, if it's causing some type of like an obstructive type process within the lower airways, you can get a little bit of wheezing there too. So that would be my general differential for this. I mean, there's probably other stuff as well. Bronchitis, maybe, though. Bronchitis is usually bilateral. It's usually some type of viral process, and it wouldn't be segmented to just this one spot. Fluid in the lungs causes usually more crackles, and if it's in one segment of the lung that has fluid in there, it's usually some type of like an infection, so inflammation in that area. Cystic fibrosis I think it can cause wheezing, but I don't think it would be of a certain segment. I would have to look that up because I don't deal with CF that often, but I think it would be more generalized, if anything. Does that make sense to everybody? Kind of the way that I thought through that? Okay. So that's a good question. So Dr. Buchanan's asking, it's a dry cough, would CF be more productive? Technically, I don't think it would, unless you're throwing down some saline in there to kind of break things up. Because with CF, it's a problem with I forget what type of channel it is. But basically, you're not able to hydrate your secretion. So all of the mucus that's out there becomes very dehydrated. And so a lot of times you have plugging of the airways and you can't bring that up because your cilia are not able to actually push that mucus up. So it would be productive if there's enough, I guess, mucus to bring it up, and then if there's enough moisture to bring it up. But you can always do a treatment where you're hydrating the lungs a bit more, and then that can help break it up and cough that up. So that's a good question. Okay. Perfect. So the rest of the exam, the cardiovascular exam, is mild tachycardia. So I guess 115 is considered tachycardic for them. Abdomen soft, non-tender. Bowel sounds are normal. MSK is okay. Patient's alert and awake. Cranial nerves are okay. Everything basically looks okay. Cool. All right. So at this time, which of the following are common and or dangerous differential diagnoses that cannot be excluded based off the history and physical exam on this patient? So we talked about an allergic reaction. Do we feel like this is an allergic reaction?
No.
Probably not, right? Because if it were, it wouldn't have gotten better. So I would leave that out. Or he probably wouldn't have been able to sleep that night and then the next morning have the exacerbation. Asthma potentially, right, because of his history, although it's not likely because it's so segmented. So do you want to keep it or leave it in? Do you want to leave it in or take it out?
Keep it in.
Keep it in.
All right, let's keep it in. Bronchiolitis. So that is inflammation of the smaller airways, the bronchioles. So that's lower down. Let me see if I can bring up a picture. So
Hey,
usually, what's up?
Can we explain why it's not an allergic reaction?
Yeah. Okay. Perfect. So if it were an allergic reaction, a lot of times, well, I guess it's going to be an allergic reaction to what? So if it's an allergic reaction to what he ate last night, typically, if he was short of breath or he was starting to have that cough right after, and then it got better, and then the next day it started getting worse, an allergic reaction doesn't typically follow that pattern. So what would happen with an allergic reaction would be that you would get short of breath, you'd start having that reaction, but it would keep going to the point where you're not going to be able to breathe well because of that ongoing process. So if he started to have symptoms right away or after dinner, was able to sleep, was okay to sleep because the cough got better, but then in the morning started feeling worse, that's not the typical time course for an allergic reaction. Does that make sense?
Okay, sounds good. Thank you.
Yeah, no problem. Okay. Any other questions? Okay. So there are a few good pictures on bronchiolitis on here, but I don't know if I can share a different screen. I'll share it afterwards. Okay. So, all right. So bronchiolitis is usually because of a viral type infection. I think 2-year-olds are still within the window for RSV bronchiolitis. But he doesn't really have a fever. He doesn't really have any other symptoms of like a viral infection, just this acute onset cough and trouble breathing. I leave it up to you guys. I probably wouldn't keep it in. Yeah, I probably wouldn't keep it in. Cool? Leave it out? Okay, and if we get it wrong, it's my fault. All right, foreign body aspiration. Okay, so why not bronchiolitis? So bronchiolitis typically is because of an infection. And so he doesn't really have infectious symptoms. So he doesn't have any fever. He doesn't have, sometimes you have a rash. Usually with RSV, you don't. He doesn't have mucus production, which typically you would. So that's why I don't have a great reason to say we 100% can say it's not, but it's just super unlikely. So that's why I'm leaving it out. We can keep it in just in case if you want. Can be dry, doesn't need to have any phlegm. Typically with RSV, from what I've seen, or I guess for bronchiolitis you can, but it's usually a mucousy process. Okay. We'll keep it in just because I'm not 100% sure, and if we get it wrong, we get it wrong. All right. Foreign body aspiration. So that is basically he was going to swallow something and went the wrong way, and now it's stuck in his lung. So what do you guys think about that? I think you guys are already saying yes. Yeah. Keep it. Yeah. Okay. Epiglottitis. And we talked about this a little bit. You guys want to keep that in?
No.
Do you guys know kind of what epiglottitis is? You want me to explain it a bit more? Okay. So epiglottitis, this is so much easier if I can pull up a picture. But if I do that, then you can't see. I'll lose my place in the case. Okay. So epiglottitis is so the epiglottis is basically that top part of the throat that basically closes off your airway every time you eat. So as you eat, you have your trachea right here, you have your esophagus here. And so it has the same upper connection, which is your mouth. And so as you eat something, the epiglottis closes down, closes off your airway, so all the food goes onto the other side. Sometimes that can be, that can get infected, or you have a virus or bacteria that can infect that specific portion. Usually you'll have infection around that too, but the epiglottis itself gets infected, gets really red and inflamed and swollen. And so if it swells too much, it can close off your airway completely. And so that's what I was talking about when the patient is tripoding forward, so that they're on their hands forward and their neck is extended, they're drooling, they don't want to swallow anything because that'll irritate the epiglottis. I will keep a list of things that I want to show you guys after we're done, so that way we don't lose our place in the case. So there was epiglottitis, and then there was bronchiolitis. Okay. Okay, so yeah, if you see a kid in tripod position, good luck. Cool. All right, so I don't think it's epiglottitis. He doesn't have any of those symptoms. He doesn't look like he's in any distress either, so I would probably leave that out. Pertussis. Do you guys know what pertussis is?
The whooping cough?
It's the whooping cough, yeah. So, do you want to explain what the symptoms are of whooping cough?
I'll try.
Mhm.
Basically, I feel like everyone kind of experienced this cough a little bit before at some point in their life, but it's that big, like deep cough. I think it literally kind of sounds like a whoop.
Yeah.
I can't remember exactly what part of the airway is affects by it, but it's particularly dangerous for infants.
Yeah, I don't know if it affects a specific area either. So the whooping cough, we actually don't see it as much anymore because there's a vaccine against it. So when you're a kid, you get the DTaP vaccine, which has tetanus, diphtheria, and acellular pertussis. And the pertussis is the whooping cough part. But what it is that it's called the 100-day cough because it lasts for so long. In kids, it's particularly dangerous because they become hypoxic really easy. So I think it affects the lungs. But basically what happens is you're coughing, and you can't stop coughing. So you'll cough for a long period of time, and eventually when you have a period, you go because you're able to breathe back in. So that's your whoop, I guess, is what it's called. And so I've seen one case of this, and it was a kid whose parents did not vaccinate them. And the kid had to be intubated, sent to the PICU, and it was very scary. The mom wanted to leave AMA, and we're like, nope, we can't allow that. Your kid is going to die. So, yeah, it's not a fun disease. It's very dangerous in kids. I don't know if it's passed from mom to kid. I don't think it has that transmissibility, but I'd have to double check. Okay. I think.
Dr. Nakeev?
Yeah, what's up?
Isn't whooping cough like very contagious too, though?
Mm-hmm.
So like,
It is.
anybody else in the family be sick or have like a history of it?
Yeah, and so with the kid that I saw, I think it was their aunt that got the whooping cough and then transmitted it to the kid. So it is very transmissible. It's very contagious, basically. Yeah, you're right. Yeah, and then I think Dr. Navneet is saying that the vaccines are up to date, so probably not that. And the vaccine works really well against pertussis, so we're going to leave that out. And then what about pneumonia?
No.
No, probably not. There's no fever. There's no other signs. He doesn't have a productive cough. So let's leave it out. Let's submit. And we were right except for pneumonia. Okay. So allergic reaction would be bilateral rather than unilateral. Wheezing. Cough is not a prominent feature. Children with asthma often have a cough and wheezing, which we included. Bronchiolitis is a common cause of cough and wheezing in young children. So I guess I was wrong for that one. Foreign body, symptoms started shortly after eating, so foreign body aspiration should be considered. Epiglottitis, there's no fever or stridor. He does not appear ill. Pertussis, so the absence of characteristic whoop of pertussis, which is not present in the first stage of illness, does not rule out pertussis. However, child's wheezing and lack of upper respiratory symptoms is not at all characteristic of pertussis. So I guess it's upper respiratory, not in the lungs. And then pneumonia, so cough and unilateral lung findings on clinical exam are common in children with pneumonia. So what's the difference between bronchiolitis and pneumonia? So bronchiolitis is inflammation of a specific part of the airway. So it's basically before the alveoli. And so usually it's a viral inflammation that is causing the bronchiolitis. Pneumonia, you can have a viral or bacterial pneumonia, but pneumonia is an infection of the alveolus itself. So that's where all of the gas exchange generally happens. And so a pneumonia, typically it's the infection at that end airway. You have a lot of pus buildup. You'll start to cough up some phlegm as well. You generally will have higher fevers as the disease progresses. I guess one thing that we should mention with kids is fevers are usually one of the first presenting signs, typically on their vitals. Typically, their vitals look rock solid until they don't. And because kids have a lot of reserve, so they'll look great until they're about to crash, and then all of their vitals just tank. And so that's the scary part about treating kids, especially kids that are really ill, is that you never really know. When they will kind of just tank down. So you want to be super cognizant of that. Another difference is that bronchiolitis can affect people of all ages, but is more common in all ages. Oh, so bronchitis, sorry, is can affect pretty much everybody. Bronchiolitis is more common in children. So yeah, so bronchiolitis is usually really younger kids. As you get older, you don't really have that same, you usually don't get bronchiolitis. You can get bronchitis, you can get a pneumonia still. But he's in the age range, if I remember correctly, where he can still get bronchiolitis. Okay. Yeah. Cool. All right. Let's go on to the, didn't it say no one else is sick in the house, so how can it be pneumonia since it's really contagious? So pneumonia is not, I don't usually see pneumonia as being super contagious. A lot of times it's, I think the viral causes of pneumonia or the viral infections are more contagious than the bacterial causes. So yeah. So as far as pneumonia goes, unless it's kind of like a viral pneumonia, like COVID can cause a viral pneumonia that can be contagious, but a strep pneumo, I don't think those are typically infectious like we usually think of. But I might be wrong about that now that I'm thinking of it. Let me get back to you on that. Okay. And then somebody asked about the bronchiolitis age range, and I think it is below 2, but I'm going to double check. Usually younger than 2 years. Peak is between 3 and 6 months. Yeah. So below 2. So patient is 2, so maybe less likely as well. But okay. Next. So at this time, which of the following is the most appropriate next steps? So albuterol, basic. All right. Do you guys want to give an albuterol? No. Yeah, we can. If we think that it's possibly asthma, we can see if it gets better with that. A BMP. So that's your electrolytes and your creatinine and BUN. Yeah. I don't know what we would necessarily get out of that unless we're thinking the patient is dehydrated, but they're not really vomiting, so probably not. Chest X-ray, anterior, posterior, lateral, and expiratory views. So this is kind of like if we're thinking of a aspiration, this is what we typically would get. Okay, what about a CT scan of the chest? Would we want to get a CT of the chest? Why not? Anybody want to say why or why not we would want to get a CT of the chest?
Is it a little bit redundant?
Let's say, so yes, it might be. We get a lot more information resolution with the CT. We can actually see the lung parenchyma, and we can scroll down and see what's going on in there. Why wouldn't we want to get a CT? radiation. So CT scans are a higher dose of radiation than an X-ray is, and so we wouldn't want to unnecessarily radiate this kid unless we absolutely have to. So yeah, typically we want to limit CTs in peds unless we need to. Okay. What about a CBC with differential? Yes, no. So I probably would, just to see if there's any underlying infectious process, although he doesn't really look super sick from what it looks like. He just looks like he's in distress. So he doesn't look septic is what I'm trying to say. But we can get it. So you guys want to discharge him home with a cool mist vaporizer? No. No. So I think somebody's asked me if CTs are expensive. Generally, they're not in the grand scheme of things. So X-rays least expensive, CTs depending on the type of CT that you're getting, it can be a bit more expensive. But a general CT is not as expensive. MRIs tend to be a bit more expensive. But okay, so we can do a CBC to rule out pneumonia. We can, but sometimes, especially in an early pneumonia, a CBC might not, you might not mount a white blood cell count like you would more advanced, for a more advanced pneumonia. So it can't rule it out completely. What's the difference between CBC with diff versus without? So a CBC with differential looks at the cell lines and breaks it up depending on what they see. So it tells you how many neutrophils are in there, how many basophils, how many eosinophils. And so depending on what that shows, it can tell us what type of process is going on. And so if you have a CBC with a really high neutrophil count, that's probably an acute process going on that your body's trying to mount a response to. The other thing is immature neutrophils are called bands, and so if you see a CBC with bands in it, that tells us that there is some type of infection usually that is making your body kind of push out these immature neutrophils to help fight whatever infection you have. So, and then the without diff is without a diff, so there's no differential there. Okay, does anybody know what a cool mist vapor is used for? It's not a bronchodilator. It's not for congestion.
Is that like CPAP or relation to
no.
like sleep?
So it's for croup. So when kids have croup, that's that seal-like barking cough. And if you YouTube croup and listen to it, it's pretty distinctive. What happens is that the cool air kind of soothes or decreases some of that inflammation, making it so your symptoms kind of decrease. And so one thing that people will tell you is that if you take a kid with croup that is struggling to breathe or like having a really bad cough, not so much struggling to breathe, having a really bad cough, and you take them outside and it's a cool kind of, especially like a misty type day, they will improve. And you'll see some parents say, oh, my kid was coughing like crazy, but as soon as we got him in the car and we were driving to the hospital, his symptoms got better. And so that's kind of a good kind of sign for croup. Heimlich maneuver. Yeah, probably not. It doesn't look like they're acutely choking on anything, and if they are, it's probably lower down. It's not a Heimlich maneuver is not going to be able to bring that up. And then somebody said yes to pulse ox, so we can go ahead and see. Okay, let's go ahead and see that. All right. So we got everything right about except CBC. So the child is wheezing, so history of reactive airway disease, therefore a trial of inhaled bronchodilator is reasonable. BNP, no symptoms to suggest electrolyte disorder. X-ray, so we can diagnose several possible causes with an X-ray. CT scan is radiation exposure. CBC. So it does not aid in diagnosis, is not helpful in stratifying degrees of illness in this patient. So, yeah. I figure, though, most people will have a CBC by the time you go and see them. Discharge with cool mist vaporizer. So, yeah, we need to evaluate them more. No evidence of large airway obstruction for Heimlich maneuver, and it's always important to assess oxygenation in a kid with dyspnea. Okay. So pulse ox is 96 on room air, and chest x-ray shows AP and lateral views are normal. Child is unable to cooperate with expiratory view. Okay, so it's not super helpful. Other than the pulse ox being normal, that helps us to know that we don't have to go and like intervene super acutely. Okay. At this time, which of the following is the most appropriate next step? So admit the child for observation, take a chest x-ray in the left and right lateral decubitus positions, discharge on amoxicillin, discharge on inhaled albuterol and prednisone, repeat attempt at chest x-ray expiratory view. So option 4, discharge with albuterol and prednisone. So do we want to admit the patient? Yeah. I don't know if we need to per se, but I wouldn't want to send him home without figuring out what's going on. And if it is an obstructive process, I think we need to make sure that we remove that. So if there's a foreign body, we need to make sure we remove that first. And so if it can be taken care of in the ER, I wouldn't admit him, but I wouldn't send him home either. So I would probably admit them if we can't take care of it in the ER. Okay. Can I explain the chest x-ray again? So the chest x-ray, so the first chest x-ray they got was the front view, the side view, and a view where they exhale to try to get a better view of the lungs. The front and side views were normal. They couldn't get the patient to cooperate with the expiratory view. So it wasn't super helpful, other than it probably is not a pneumonia, because we would typically see a bacterial pneumonia there. So taking a chest x-ray with the left and right lateral decubitus positions, I probably would get that, although I'm not exactly sure what we would see different on the left and right lateral decubitus position. So what lateral decubitus means is basically you're just laying on your side. So you're going to lay on your left side, take an x-ray, lay on your right side, take an x-ray. And this is just me not knowing what that will show. So let's get it anyways and see. Discharging amoxicillin, we already talked about, we probably don't want to discharge this patient. Plus, it doesn't seem like an infectious process if there's no evidence of pneumonia. So no, we didn't see anything on the left lung when on the first x-ray. So we don't want to discharge on amox. We discharge on albuterol and prednisone. Albuterol might help if this is a reactive airway. If we think it's an asthma exacerbation, the prednisone will help as well. But we got to make sure it's nothing else first. So I wouldn't do that. And then reattempt x-ray expiratory view. I mean, we can do that. I just don't, if the patient's not cooperating, you might be wasting more time. So further attempts at making a diagnosis are indicated. So we don't want to admit them yet. Although sensitivity is not high, these views can help diagnose an airway foreign body in the airway. Okay. So I hope they have a x-ray here so we can see that. No evidence to suggest bacterial infection. They didn't respond to a single bronchodilator treatment. Diagnosis needs to be clarified. And then if the techs were unsuccessful initially, they're unlikely to be successful on repeat attempts. Any questions about anything so far before we move on? No? Cool. All right. Oh, cool. X-rays. So, test results of the X-ray in the left and right lateral decubitus positions are shown. I don't know how well that shows up for you guys. I don't. Let me see. Okay, so bear with me here. So the airway, we can see it here pretty patent on the left side. I can't really see it coming down. That just might be my own, my computer. So the bones look okay, and it looks like a good film in general. The patient's not like rotated or anything like that. So the clavicles are symmetric, so it's not a lot of rotation. Looking at the ribs, I forget how many ribs you want to see in a kid, but in adults you at least want to see 8, and this is more than 8. 1, 2, 3, 4, 5, 6, 7, 8, 9. The cardiac silhouette. So I have my I probably should explain this. My way of looking at X-rays is I go through the A, B, C, D, E method. So A is your airway. So you look at the trachea coming down, breaking off into the bronchi, and kind of just following those down. Like I talked about, I can't really see that left one as well, but that just might be my computer. B is your bones, and so you look at all the ribs, you look at the clavicles. The clavicles will help you tell if the patient is rotated or not. It might be a little rotated a bit. And then I also look at the spinous processes of the spine, and this patient actually has a little bit of rotation there because you can see that it's kind of curved this way. And then also don't forget to look at outside the bones of like the humerus, the scapula. Sometimes you will patients will have a fracture there that somebody misses. C is the cardiac silhouette, and so you look at the borders of the heart. Everything's pretty sharp and well demarcated. Kids will have a little bit more of a kind of a widening a little bit of the top of the heart because they still have their thymus. But so if you see that, if there's a big shadow here, that's okay. It doesn't mean that they have like an aortic dissection like we talked about before in adults. D is the diaphragms. So you look at the diaphragms, it should be very sharp. If it's not sharp, if there's any fluid here, you'll see it as kind of more obscured. There'll be a bit more of a shadow there, and everything looks sharp there. Everything looks sharp here too. And then E is everything else, and so that's looking at the lungs themselves. So the lungs actually look pretty clear. The markings kind of come to the edge here, so it's not like a pneumothorax or anything like that. It looks good to me. Let's see the other side. So that was right lateral, that was left lateral decubitus, right lateral decubitus. Huh. It looks strange. So the obvious thing is that there's way less lung markings here. I don't. And then there's a bunch of, it's a lot more dense, I guess, in this area. So there's more lung parenchyma here. I honestly don't know what to make of this X-ray. Does any of you guys know?
Didn't it say that like the wheezing was in the left lung, but it was like pushing like transporting something to the right lung? Like, could it be that like it is some sort of like fluid or something that was like caused by the wheezing and then transported to the right lung?
So they said that the kid had transmitted airway sounds. So what that means is that you can hear some of the sounds from the left side on the right side. So it doesn't mean like there's any like transmission of fluid or anything like that. So it just means that the sound is heard on the other side. And you'll see that a lot too when you listen to a kid's lungs, and if they have like some type of stridor or something up high, and you listen to the lungs and it sounds like you hear that same sound in the lungs. A lot of people will think that, oh, there's something going on in the lungs, but if it's the same sound and you hear it louder in the neck area, if you put the stethoscope on the neck and it's louder than in the chest area, it most likely is transmitted from up high. So, yeah, I hope that answered your question. Yeah, I don't know what to make of this X-ray. Can it be due to fluid in the lungs? Fluid would typically be a bit more, a bit more white. So the fluid won't look black like this. On the other side, he has good lung markings. So, but everything looks more compressed on that side. But what we were saying.
Sorry, just what's the difference between like the right and the left side? Because like the way you explained it, it was like going one way, like laying on one lung versus like laying on the other. So like, why would they look different at all?
That's what I'm trying to figure out. I'm trying to figure out what the left lateral versus right lateral decubitus shows. So let me see. Does any of you guys know? Due to fluid in the lungs. I'm gonna just look this up super quick. Sorry, guys. So they're saying that there can be signs of air trapping. So patients with obstructive foreign bodies will not have a collapsed lung, however, will manifest hyperlucency in the dependent lung. Sure. Okay. Okay. So okay, so let's go back to this. Let's see if we can figure this out. So the left lateral decubitus position looks okay. So this left side looks okay here when he's laying on this side, but on the right side, okay, I think I know what they're getting at. So from my understanding, this left side of the lung here is a bit blacker because what air shows up as, something black, right? So that's why your lungs are a little bit more like a grayer color than your bones because your bones are more solid. And then if you look at the airway over here, where the actual, I guess like where the trachea comes down, that's a little bit darker because there's more air in there. So when we look here though, what they're saying is that air trapping, so if there is a foreign body, which is I guess why you would get this view, you have air that's trapped in these lower portions of the lung, so it looks a lot darker. Does that make sense to everybody? So it kind of makes sense to me. I'm just not, I still have to learn the pathophysiology behind all of that, but I think that's what they're getting at.
So the foreign body causes the air to be trapped.
Yes, that's what it seems like. So the way that I can conceptualize it is as the air, I guess, can't come out of that lung, and so maybe also that's why they wanted an expiratory view. So in an expiratory view, you breathe out, and if your air can't get out of that lung, then it's going to look like a darker spot within that view. So with this, when you're in the lateral decubitus position, what they're saying is the dependent side. So I'm assuming that is when you're not laying on that left side, because the patient's problem is on the left side, it seems like, you're going to have more air trapping. And so because of that, you'll see it darker because air shows up darker on an x-ray. And so that's what they're trying to show with this over here. In all honesty, I don't completely understand it. I will read up a little bit more about what happens, and I can always get back to you guys.
So I have a question, just kind of
Yes.
to make it make sense for me. So when the purpose of having taking the image on one side and the other, is it to see if the air that's essentially trapped and whatever lung it is gets moved to the other lung?
I don't think so. I think it's more of that portion of the lung that's affected. So within your airway, when the foreign body obstructs that airway, I'm assuming potentially you can get air in, but you'll have a harder time getting the air out. And so when you're testing to see if the air gets trapped as you lay on the opposite side, that part I don't quite understand why it would be the opposite versus the same side. But it looks like as you lay on that opposite side, some of that air gets trapped, making the airway look a lot darker, like it does here.
I see.
Yeah, I'm the same way. I'm like, I kind of see.
Like I see it, but
you don't understand why. Yeah, that's the same with me. I don't completely understand why this happens. So I will look it up and try to figure that out. And I'll let you guys know. Cool?
The way that I was kind of thinking about it, which could be totally wrong, is like if you're laying on this one side, and the problem is in the lung on the bottom, then they're gonna look normal. But if you like turn to the other side and then now that lung is like against gravity, like it's going to look like there's less air in that one. I have no idea if that's right at all, but like that's the only thing that I can think of by sides.
Maybe because that actually might be what's going on, because technically, so you're right. I think that gravity is compressing that lung parenchyma a bit more, so you're making it. So if I get what you're saying, maybe you're making it so the trapped air isn't as prominent because there's less, I guess, it's a more dense tissue. Potentially, I don't know. That makes sense. That kind of makes sense, but I don't really know. I'll look it up and let you guys know. Or if anybody else looks it up, maybe you can let us know too. Okay, let's move on. So what is our diagnosis? So asthma, do we think it's asthma? Probably not, right? Yeah, no. Foreign body in the left lung? Yeah. Probably, yeah. Foreign body in the right lung? Probably not. Pneumonia in the right lung? Probably not. Everything is questioned after that x-ray, yeah. Yeah. And then tension pneumo in the left lung? Probably not. Yeah. I thought right lung. So the patient's symptoms are, when you listen to them, it's all on that left side. And then on the lateral decubitus view here on the right lateral decubitus view, this is the left side of the lung. So the L there shows you this is the left side. So it looks like the left side is where it's affected.
So the left side has the central like air trap, and when you're saying that if they're laying on their right side, by gravity, that the image will show the, I guess, trapped air better on the opposite side, which is the left lung. Correct?
Yeah, because if you look at the left side here, when they're laying,
it looks more normal
on the left lateral decubitus. Yeah, so they're laying down on this side. So the thought is that everything is being compressed down this way because of gravity. And so you can see that the right side is a bit more expanded here than the left side is. But the thinking, and this is just our own kind of thinking about it, is that everything's being pushed down more, so there's more lung tissue in the same volume, or it's the same space, making it so that even if there's trapped air in there, you're not seeing it as black because of all of the tissue that's there as well.
I see.
Does that kind of make sense?
Yeah.
Okay. All right. So I think we're saying foreign body, left lung. Yes. So failure of the left lung to compress when in the left lateral decubitus position means that air exit is impaired on the left, likely from a foreign body. Wait, failure of the left lung to compress when in the left lateral decubitus position means air exit is impaired. Wait, hold on. What? So they're saying that because it doesn't compress as well. Oh.
Is it saying because there's air inside of that, it doesn't allow it to compress because?
Yeah. Okay. I think I know what they're saying now. So if we look at these two X-rays here, when we look at the right side, the right is super compressed, right? There's a small volume here when they're laying on their right side. I think this is kind of the black spot here might be just a red herring that we're focusing too much on. But basically the heart and all that tissue is compressing this right lung more when they're laying on their right side. When they are laying on the left side, you don't have that same compression. The lung is still pretty well expanded. And so it would be harder to compress a lung that has air trapped in it because the air is it's kind of like a balloon. It's keeping everything inflated. So you don't have that same smaller area. Does that make sense?
Yeah.
So like the first one, the one that we thought was normal is actually the abnormal one.
Yes, exactly.
Cool.
Yeah, so this is what they're talking about. They're laying on the left side. You still see a lot of lung parenchyma here, versus on the right side, when you're laying on the right side, you can hardly see that lung right there. So this is like a balloon being held up because there's air trapped inside.
Yeah, you really, because they said the image was taken after they were exhaling, correct? So they're trying to get an image with reasonably no air inside the lung.
So I don't think this one matters as far as inhalation or exhalation goes. Or actually, I don't know that. I think it doesn't matter. But what they're saying is that that the fact that this doesn't compress with the gravity of everything else coming down means it's literally just like a balloon. So
a balloon. Yeah.
The balloon is tied off, and as much as you push on it, the air is not going to come out. Versus on the right side, this balloon is like it's opened out to atmosphere, to the rest of the world. And so as you push down from that side, the air is able to escape out because it's not trapped, so it compresses down. Does that make sense?
Yeah.
Okay. And if it doesn't, if anybody else is still confused, let me know. I can try to explain it a bit better. Hold on. Let's just make sure we didn't miss anything else. Okay, I don't think there was anything else here. The decreased density in the left lung in the right lateral decubitus position is normal. Okay, so what we were first thinking about being abnormal is normal. All right, at this time, which of the following are the most appropriate treatment orders? So consult ear, nose, and throat or pulmonary specialist for bronchoscopy, gram stain for culture, amox, so that's augmentin, back blows with child in an inverted position, suction airway with a flexible calf. So we need to remove the foreign body, I agree. So you want to do it with airway suction, back blows, or consult ENT or pulm. Yeah, I would agree with that. Okay, the patient needs to have bronch for definitive diagnosis and removal of foreign body. The specialist chosen may vary by institution. The patient had a rigid bronchoscopy done by ENT. A piece of carrot, was found in the left main stem bronchus and was removed. So do you guys know what a bronchoscopy is?
Is that when they go and look inside the lungs or the bronchi?
So yeah, so kind of like an endoscopy. So for an endoscopy is what we use to kind of look into the stomach. So we put a camera down the throat into the stomach and take a look there. A bronchoscopy is the same idea, but you're going into, instead of going through the esophagus, you go through the trachea, go down and look at the two bronchi, and kind of go down as far as you can and see what you can see. I've done it before. It's super, super cool. It's literally like playing a video game because everything's on a screen and you're controlling it with this controller. And you can squirt some water in there. You can suction things out. You can, depending on the scope you have, you can take biopsies. It's really cool. So yeah, I think somebody said that back blow seems aggressive. So it is aggressive, but if somebody's choking on a carrot or something, or choking on something and it's obstructing a larger airway, you need to get that out. So you will do really aggressive back blows to try to push that out. So it sounds aggressive, but it's necessary. Okay. We all know why we're not going to gram stain and culture. It's probably not. It's not an infection. I guess they're unlikely to produce useful sputum. It's not likely an aspiration pneumonia, so that's why we're not giving augmentin. The maneuver is for a complete airway obstruction in infants and would not help in this case for the back blows. And then suction with a flexible calf increases the risk of vomiting and further aspiration. Also, a suction calf is difficult to get past the glottis in an unconscious patient, and a flexible calf does not remove solid or semi-solid foreign bodies. Okay. So which of the following are considered typical manifestations of acute bronchial foreign body in children? So cough, drooling, dysphagia, unilateral diminished breath sounds, vomiting, or wheezing. So a cough, probably, right? Because that's what this case is. Drooling, yes or no? Probably not, right? That's more like an epiglottitis or upper airway. Dysphagia means that they can't swallow, so probably not. Unilateral diminished breath sounds, maybe, probably, yeah, right? Because if you have a bronchial foreign body where it's completely obstructing that, maybe. But you might have an incomplete obstruction and it wouldn't cause unilateral breath sounds. A dimension, we'll keep it. Vomiting, probably not. Vomiting, if you have a large airway obstruction, one response is to vomit, and that helps compress the abdomen and try to help push that air out. So, but not in this case. And then wheezing, yes, right? Cool. We got those right. Which of the following are typical complications of an unrecognized bronchial foreign body? So atelectasis means basically the airway, the small airways, the alveoli are more collapsed. If you have a obstruction and you can't get air in, those airways I think can collapse, so you can get atelectasis. I'm not 100% sure, but I think so. Asthma. Is a foreign body going to cause asthma? Probably not. Bronchiectasis. Bronchiectasis. The bronchial tubes of the lung are permanently damaged, widened, or thickened. So probably not. It is a typical complication. I actually don't know. Yes, no. We'll say yes. Question mark. I don't know. Emphysema. Probably not. So emphysema is I'll give you the exact definition, so I don't give you the wrong thing. So emphysema is basically the air sacs in the lungs, so the alveoli are damaged and they become very flimsy and floppy, and you're not able to compress those out to push the air out anymore. So usually we see that in long-time smokers who've been smoking for a long period of time. So no. Lung abscesses. Would we see an abscess in the lung? No. I think we might, because you're having a foreign body there. It might cause an obstruction. It can cause a pneumonia. It can cause, I think it can become a nidus for infection. So I think yes. Lung cancer. No. I don't think it would cause lung cancer. And then pneumonia. Can it cause a pneumonia? I think so. Because you're basically blocking off a airway, and so you're not able to push air out like you normally would. So I think yes. Yay, we got those right. And these are unrecognized foreign bodies. So that means that we don't know. We miss basically the foreign body in there. Okay. Which of the following is the most common location of foreign bodies aspirated by young children? So then the alveoli, the bronchi, the larynx, or the trachea. The trachea is up high. So this is your trachea here. So that's probably like a complete obstructive process. They're choking, turning blue. The larynx is where your vocal cords are. So the larynx probably not. The bronchi, I think most people are saying bronchi, and I would agree with that. The alveoli are the very small airways, so it's really hard to get. You have to aspirate on something super, super small for it to go down into the alveoli. So I think it's the bronchi. Yeah. Bronchi. In which bronchus is a foreign body most likely to be located in a child aged 1 to 3? Left, right, or either? Both, either. So I think it's the right side. And so the way that I used to think of it is, if you aspirate on something on the left side, you have your heart there. And so there's a difference in the degree at which the bronchus branches off. So if your trachea is coming straight down, your heart being right here causes the bronchus to be more horizontal. Whereas on the right side, it goes kind of more at a more acute angle. So it comes down, it's like this, or this on the left side, this on the right side. I don't know if you probably can't see that. So like this. And so if a foreign body is coming down, it's going to have an easier time going down that right side instead of the left side because it's more kind of a straight shot down versus on the right, it has to kind of turn this way, if that makes sense. Let's see. I was wrong. On the left side, in this age, the main stem bronchi diverge from the trachea at an equal angle. Unlike those in adults, the foreign body is equally likely to be in either bronchus. Oh, it's on either. Sorry. So yeah, I was thinking of adults. So it's equally likely. Yeah. Well, let's go back and see. Hold on. So if we look here, it, I guess, kind of comes down. Maybe that's it right there. So yeah, they kind of come down at a similar angle down this way and down this way. Okay. We all learned today. All right. So we did that one. Okay. So foreign body aspiration is common among children, particularly those aged 1 to 3. However, children under age of 1 are at a high risk of aspiration if they are fed high-risk foods, grapes, nuts, chunks of meat by caregivers. So between ages 1 and 3, children are able to find and ingest a variety of objects, although aspiration can occur during the course of a normal meal. Before age 3, a child's swallowing coordination is not well developed as it is after the age of 3, when children are better able to chew food thoroughly and have the oropharyngeal control to better swallow it. Children may present acutely, particularly if someone witnesses a choking episode. However, if choking is not witnessed, presentation may be delayed until infectious complications occur, sometimes weeks to months later. Prevention is important. Toys that present a choking hazard are labeled and must be kept away from small children. However, foods that present a choking hazard are not labeled, and prevention requires extreme awareness and vigilance by parents. Okay. So do you know why the angles become different as we age? It's because, I think it's because of how our lungs develop and grow. And so as we grow, the lung becomes bigger. The heart is not quite as big, but you have a little bit of a degree of more horizontal degree of that left side because the heart is still there versus on the right side, it becomes more straight and narrow up and down. And that's as we kind of grow and your lungs kind of grow downwards. All right. I think they're more uneven just also because of how we grow and how how small the lung volume is itself. I don't have a great answer to that, but I do think it's because of the general anatomy and what's in that area. But I'll try to look it up and see if there's a specific reason why. Any other questions that you guys have?
Kind of unrelated to the case, but I remember we were discussing a little bit about CF. A way that you can treat that, can you do you kind of like beat on the chest to allow the dry mucus or whatever to break up?
Yeah, so you're saying cystic fibrosis, right?
Correct.
Okay, so with cystic fibrosis, yeah, you'll have one way to break up that mucus and try to cough that up is they sometimes have chest physiotherapy. They basically put this vest on and it vibrates the chest to try to break that up and have you cough it up. At the same time, they'll usually give you some inhaled saline so that you can moisturize the airways. At home, they have these, I forget what they're called, these little devices that help percuss the chest, and that will help bring that up too.
Okay, thank you.
Mm-hmm. What other questions do you guys have? What about, so this is technically the last time we're going to be together as a group, which is kind of sad. But what questions do you have about the program, about like the future of this? So Dr. Darcy's asking, would you use a nebulizer to administer? Yeah, so you would use a nebulized solution to get down into the airways. So as far as kind of like the future of what we're gonna do here, what I will do is, you know, doing these cases in general don't take me as much time to prepare for. It really doesn't take me any time to prepare for it, which you saw here. I messed up a lot, but that's okay. We're all learning. I am going to probably focus a little bit more on making sure the curriculum that I have for the cases that we did was more concrete and more organized. So, and we're probably going to have new cohorts of students coming in, most likely a smaller group. And so what we will do is, I don't know when the next cohort is going to be. It's probably going to be in a few weeks that we're going to start. I am going to put together kind of what I need from you guys to help me out if you wanted to join the team to help. And what I will do in the meantime is I will try my best to have weekly cases like this where we go through cases together and you and I will both learn together. I will try my best to include some variety, but because I don't know what the cases are, it might be a little bit more difficult to do that. Okay, so does that make sense? I am planning on having another session like this maybe next week too. So this is not a goodbye forever. If you guys want to still join me to do stuff like this, you're more than welcome to, and I'll post a schedule. If you guys stay in the classrooms, I will probably use that to communicate for now. But Facebook is also a good place to get a hold of me, and then TikTok, Instagram also is okay. How many hours do we put for the whole round? So it's up to you. I put restrictions on initially just because I didn't want people claiming they did like 40 hours a week on this. I would say up to 10 hours a week is okay, but just be honest with the amount of time that you put into it. And then at the end of, I know for the last few weeks it hasn't been as consistent, and so I would probably average your time over 6 to 8 weeks, whatever, instead of like, I think we kind of went for like 10 to 12-ish weeks. I have to count the actual weeks, but yeah, so at most I would say maybe about 10 hours. And if you did less, definitely put less time. I don't, just be honest with the time you put into this. Okay. Did that answer the hours questions? Because I'm seeing a lot more questions about this. And if you already submitted your application with less hours, it's okay. You can always, if they do contact me, we can always clarify that students spend up to 10 hours a week. Certificates, yes. I will be putting together certificates. I will try to figure out a way where you can type in your own name, so I'm not relying on, so you're not kind of waiting on me. And then I'll insert my signature and it'll be sent to you. So I'll try to figure all that out, and I will get you the certificate of completion for this. I don't know when the next sessions are going to start. It'll probably be in a few weeks. I would say I would keep it to about 8 weeks, though, as far as like for our session here. If you're putting it on an application, make it 8 weeks. I think that consistency is probably the best, even if it was a little bit more, because I think it might be a bit more than 8 weeks. But because there's some weeks where we didn't quite do anything, it's going to be a bit different. I mean, it'll kind of average out with the 8 weeks. Okay, just put the hours, and then add in field. Okay, yeah, that's what I was gonna probably do with the PDF creator or something like that. You can join future cohorts if you want, and you can add, as many times as you're part of this, you're able to add that into your applications too. It will be different classrooms. I'll create new codes and all that stuff so that we can focus on those. But I will probably leave these classrooms open just from a communication standpoint. It's probably a little bit easier. So yeah, if you want to reapply to it, just fill out the wait list if you haven't done so already. That way you have we have your name down. And the wait list is I have a link tree on my Instagram and my TikTok, and it should be in there. You will hear about them on TikTok, on Facebook, maybe Instagram. I will probably start posting more on Instagram. I just don't. I'm not very good at it, is what it is. TikTok might get banned today. Who knows? My Instagram is just at Abbasnakvi. It is in my. If you go on my TikTok, you look at the link tree there. There's a link to it. All right. What other questions do you guys have?
You said for this potential like group, you said you would send out an email. I think you mentioned that in a announcement.
I'm sorry, for the what?
You were talking about like a group to help you organize.
Yeah. So I will send out kind of what positions are needed, and we can go from there. You'll most likely have to submit like a CV, and maybe kind of like a little paragraph of what it is that you want to do, or your vision or something like that. And so I haven't worked out those details yet, but yeah, I'll send that out.
Okay, thank you.
I'll probably, and that's one of the reasons why I'm going to keep the classrooms open. It's because I'm going to probably post that in the classrooms, because it sends you all an email, and that's the easiest thing for me to do, to just get you guys that are here in the classrooms right now. Because Facebook has people that haven't gone through the classes yet, and I want to open it up to you guys first because you've gone through this process already.
Thank you.
We still have access to the classrooms to submit notes and everything. Yes, you do. I will post the post quiz. I do understand that you guys didn't have the same teaching as you did for the chest pain, but I do want you guys to try it out and see how you do. And then we'll have a session where we review those answers as well. Okay. So you do have to reapply to be in the next cohort of students. That is going to be probably in the next few weeks, where that's going to be starting up again. The classrooms that you are in right now will stay open, but I will create new classrooms for the new kids that are coming in. So if that makes sense. So I have restricted the letters of recommendation that I'm writing to people that I am working with. Usually it's probably going to be within these, I guess, within the team that we're trying to build, because I don't want to write you a crappy letter. I think I need to make sure that the letter that I'm writing is specific to you, and it is going to help you in the long run. So there's a few letters that I need to write already that people have worked with me already for. So yeah, if you do end up working with me, I'd be happy to write you a letter though. The waitlist link is in the link tree is for the course in general. And so we're going to be picking people off from the waitlist. The waitlist itself, I think there's a ton of people already on it, but I anticipate some of those people not wanting to continue because school is going to be starting up again. So yeah, fill out the wait list though. Does the syllabus state what you want us to call the program? Yeah, so I called a few medical schools and they weren't sure what to call this either. I leave it up to you guys. You can call it clinical experience, or you can call it shadowing experience if you'd like. I don't think there is a right answer to it as long as you explain why you think it's one versus the other. So like if you call it clinical experience, you're doing clinical medicine by doing like morning report type rounds, talking about patients, and the cases that I put forth for you guys, those are actual patient cases. They're changed obviously to protect the identity of the patient, but it is actual medicine that has been seen in the hospital and all that. So you can justify it that way. If you already have clinical experience and you want to just put that this is shadowing, that's okay too, but just explain that if you do put it as shadowing, explain that you were more of an active participant and you were learning about medicine and all that. So you get a little bit more credit than what typically is done for shadowing.
Wait, but I'm sorry, Dr. Nuffy.
Yeah.
For you posted like a sample like description of the program on Google Classroom. Would that be enough? Because I don't know which one I'm putting it as either, because I'm still talking on college. But should I just put that description you put on Google Classroom, or do you want me to be more in depth?
You can use that. I leave it up to you. That's kind of more of a sample. You can change it to however you want. I know I want you guys to change it a little bit so it's not like they see multiple people with the same thing. But use that as a guide as to what you are going to talk about. And as far as like designating it as clinical or shadowing, it's up to you. Does that make sense?
Also, yeah, that makes sense. And also I have like another question.
Yeah.
I don't know if you touched upon this before, but for joining like the team and stuff, I want to join the next cohort, but like on the interest form, I also said I want to join the team. Is that enough, or like do we like submit our application or something like that?
Yeah, so I'll send out an actual application form. I have the people that were interested in helping out already, but just to make it easier on me, because some of those interests might change over the last 8 weeks that we've been working together. So the form that I'm going to send out, it'll be for specific positions.
Will that be on the classrooms, or would it be like on your?
I'll post it on the classrooms first, and depending on what response we get, if we fill up based off of the people in the class already, I probably won't publish it outside of the classrooms, just because I know you guys know what this program was already, so it makes it a little bit easier for me. But aside from that, if there's still positions that I need, then I will publish it outside of the classrooms.
Okay, thank you for hosting this. It was like a really good experience.
Yeah, for sure. Okay, so okay. I think I answered everybody's question, and you guys are really welcome. I had a lot of fun doing this, and I will try my best to continue to provide more opportunities like this. And if you have any other ideas of what you would want me to do, please let me know. One of my co-residents, he's incredibly smart, way smarter than I am, and he's very funny. Me and him were talking about doing a podcast, not so much about like pre-med advising or anything like that, because I think that's done to death, and I don't think it's super helpful. Like if I were to go on and do that too, but we're talking about it. So if there's anything that you would want to see in like a podcast or something like that, just let me know too. It would help kind of define what it is that we want to talk about. And then yes, for all of the people here and on YouTube and all that are Muslim, Eid Mubarak to everybody as well. If you want to, you can use the email to contact me. That's probably, with anything that has to do with the classes, that's probably preferred. If you have a question as far as like your like pre-med journey or whatever, you can text me. My number is on my TikTok, and so it's on my bio, so you can just use that to text me. and you can also do Instagram. I check that pretty regularly as well. There's some people that message me I haven't gotten back to, but I will get back to you guys. Yeah. So anything with the classrooms, just send me an email. So not questions about medicine, but questions about how to talk about the program. So yeah, you can email me those. Okay. Any other questions that you guys have? Okay. All right, then we'll call it a day then. You guys are amazing. I had a ton of fun. I hope you guys learned something and grew from this, and I am excited to see what everybody does. You guys should all keep in touch. All right, you guys are welcome.